Okay, I think we should give it a start and we'll get the chairs.
Yeah, let's
so
start.
we can
And then we'll
get
get
on with the
the chairs. We apologize for this IT glitch. It's not any of our fault, but these things happen, as you probably know. And so we'll carry on with our presentations and we'll start our course. My name is Dr. Moayad Aziz. I'm consultant anaesthetist and intensive care unit from Wales in UK. I'm going to talk about recognition and prevention of deterioration using ABCD approach. As you probably well know, detection of deterioration or recognition of unwell patient is very, very important in making survival. Now, the learning outcome is to understand the importance of early recognition and to assess patients using ABCD approach and to identify and treat cause of cardiac arrest. Now, just one advice, I'm probably going to help you through the day. If you're going to ask, if somebody asks you, what's this patient going to eat? You said, I'll go and do A, B, C, D, E. If he's going to ask, what's this patient going to need of coffee or what? I'm going to do A, B, C, D, E. If the patient comes from theater, patient comes from A&E, patient from in the ward, when you go to see a patient, what you do? Excellent. So A, B, C, D, E is today's your, what you call it? Keyword. Well done. Right. So, the chain of prevention is important. Important why? Because it assists in preventing deterioration. So we pick up deterioration before it happens. Prevent cardiac arrest because we have prevented the deterioration. And we also pre-admit the patient.
Can we speak up a bit?
Speak up a bit, yeah. And we also pre-admit the patient to ICU for further management, and that's all will reduce your mortality, your death. Now the sequence or the chain of prevention includes education, and this is probably part of what we're doing now, but also include educating the nurses and the staff in the ward, as well as patients. And that's important as we are the medical professions. We are the leaders in the hospitals. So we have to educate other people how to identify sick patient. Monitoring is important. We start monitoring as early as possible. Observation of the patient can be 1 hourly, 2 hourly, 12 hourly, or can be continuous monitoring. And then we do recognizing the signs of unwell patients and act on that basis. Now, the outcome from hospital cardiac arrest, if you can see here, there are patients who, it's probably 11% of patients on non-VF will survive in comparison with 49%. But one reason behind that is that when you recognize VF and you deliver the shock, the likelihood of survival is more. And when they survive this incident, the likelihood of discharge from patient alive is more as well. Now, can I ask you, do you use any of these early scoring charts in the ward, in the hospital? Okay. Who use it in the show of hands? Okay. What do you use?
What chart you mean?
What chart?
A chart of vital signs.
Vital signs.
Yeah.
Okay. Do you have a scoring system on that chart? Okay.
You
So,
mean news score?
huh?
That's what
News, yeah?
Yeah.
Excellent. So do you use the news in your hospitals? Not all hospitals, but it's probably a good practice to use it in all hospitals in your practice, because that's when you pick up the patient who start to deteriorate. and the patient is not going to do well. Now, if you know, if you see this, basically it takes the vital signs, and it's graded or scored according to the severity, and then give you a scoring number that is not only give you the level of attention need, but also give you what sort of observation. So if you score 0 in the ward, probably 12-hour observation is fine. But when you score more than 7, that needs to have a continuous vital sign observation. This is very important. And in our practice in UK, the patient who scores there, the doctors will be informed. But when you score 5 or 6, the outreach team and the intensive care team will be informed as well. So at that point, if you don't pick up the patient will pass away. They'll die. More likely will be die. Now, the causes of deterioration, as you know, is there's either airway obstruction, breathing problems, or circulation. And that's why it comes the A, B, C, D, E. Okay? So today we're talking about airway, breathing, circulation, disability, and exposure. Why we need ABCD approach? As I said, we need to build up a language between all of us, a language that we all understand. So when you hand over a patient, when you speak to a colleague, when you manage a colleague as a team, a patient as a team, you all follow the same system. The ABCD approach as well requires the personal safety, how to recognize the unwell patient, so to speak the patient, to make them, to shake them to see if they are with you or they are unconscious, and also to look at the vital signs. Now, if we're talking about airway, obviously there are different reasons for a patient who loses the airway. It can be local, it can be central, yeah. It can be swollen tongue, it can be laryngospasm, it can be head injury. All these cause airway obstruction, and that's we need to assess it first. The airway is first because if you interfere with the airway, you may save the life. Recognizing the obstruction impaired. Basically, what we look is to ask the patient, "How are you?" If they sound well, "I'm fine," then that indicates the airway is fine. There's no obstruction. They can speak. They can talk. They can deliver high voices. But then, if they not, if they have impaired consciousness or vocalization, they will think of something obstructing the airway. You need to act on that. A treatment, in addition to high flow oxygen, may include airway, like a Godel airway. It may include the nasopharyngeal airway, or may include advanced intervention, like intubation or IGL or LMA. Breathing is the second step, and then you will look to see the causes of, obviously, the breathing disorders can be this decrease in respiratory drive, centrally mediated, or can be lung disorders like pneumonia, pneumothorax infection, or can be decrease in respiratory effort due to muscle weakness. Sometimes like restrictive chest defects, flat chest, all these cause breathing disorders. With the breathing recognition, we look and to see if there is we assess the respiratory rate, the rhythm, how shallow, how deep, the use of accessory muscles, and then listen if there's any noisy breathing or the breathing sound doesn't look right, and then feel the expansion and percussion of the chest. These are probably the basic techniques we use in assessing respiratory system. Treatment can be different from oxygen only to some intervention for pneumothorax, so it depends on the cause you identify in your assessment. Circulation, obviously there are quite few causes of that, so there's the acute coronary syndrome, probably the primary cause, the arrhythmias, the hypertensive heart disease, and also there are the secondaries like asphyxia, hypoxemia, blood loss, and so forth. With the recognition of circulation, we look at shortness of breath, syncope, poor peripheral perfusion is important. We look at the pulse, the tachycardia, the blood pressure, and then we look at the organ perfusion, like urine output, and mental status. Okay. Obviously, IV cardiac is important. If we can't, then intraosseous is the alternative. And hemodynamic monitoring is essential on that stage. Now, disability include the cause of disability include the intracranial hemorrhage, the hypoxia or cerebral hyperperfusion, and it can be hypothermia or hypoglycemia. So recognition is we use the AVPO, which is the aware or awake, respond to verbal stimuli, to painful stimuli, or unconscious. And that's very simple way to recognize. We can use obviously GC Glasgow scale as well. The treatment of disability is by oxygen for appropriate, and also to treat the underlying cause, obviously. The exposure is to remove all the clothes and then to avoid heat loss and to measure the, looking for remove our clothes, look for injuries, bleeding, and rashes, as well as avoid heat loss and maintain dignity of the patient. Now, as a team working in hospital, it's very important to hand over patients to each other. And we have to have a system of handing over that is concise and that is delivering the message we want to hand over. And we came, in the UK we use the SPAR tool, and there's some other tools that SVPR, which is used as well. But SPAR tool is probably something that's simple and easy, and we should all use it more frequently in our handover. Can I ask if we use do you use any of these tools in your hospital? SPAR, anybody use SPAR?
Yes,
Yeah?
in what?
In the what?
The shifts, yeah.
Okay. Do you have a regular handover between the
Yes.
teams?
A
Excellent.
written and a verbal.
Okay. And do you use this sort of system in handing over to a consultant or to registrar or?
Sure.
Okay. So it's a very simple and easy a tool to use to hand over, communicate with other colleagues, whether senior colleagues or the other team. And S is basically situation, so it's a concise treatment, a statement of the problem. Okay, like Dr. Ranj, my name is Moayad Aziz. I'm the consultant intensive care unit. I want to speak to you about this patient who came with head injury. Yeah. He was involved in a road traffic accident, the background, yeah, and sustained a severe brain damage. And CT scan shows such and such. And my assessment, there's dilated pupils, not reacting, and so on. And what I suggest is I take him for further management in your unit. Okay, so that's very concise, and deliver the message you want to deliver to your colleague, whether in the same hospital and the other team, or whether handover between the colleagues in the same team. Okay, so that's the SPAR tool. I hope you probably take it home today, that you can probably start using it. I'm sure you are using some system in your communication that may not be structured, but if you apply your knowledge into this tool, you'll find it a lot easier for you. Okay? So the message to take home today, A, B, C, D, E, S bar. Okay? Any questions?
I'm sorry, what about this spine, cervical spine?
Okay, that's a good question. The probably if you do the trauma resuscitation course, they start with C, A, B, C, D, E. Okay, that makes sense. But for this ALS training, we assume that we are dealing with non-trauma patients, a patient who deteriorated in the ward or patient sustained cardiac arrest in the street. But still, if the patient if there's any history of trauma, then C, A, B, C, D is applicable as well. Any questions? Thank you. Okay. So our next speaker, Dr. Firas. Where is he? Where's Firas? Okay, so Dr. Firas is a consultant trauma surgeon in Bakuba Diyala, and he's joining us to help in delivering this course. He's going to talk about the basic life support when he comes. Thank you. So can I ask you, whoever used the news score, who does the observations? Is the patient, is the nurses or the doctors?
Nurses.
Nurses. And how often they do it? They do it
According to
as required, yeah?
According to the school. They
Okay.
make reservation to the school.
Okay.
It depends on the situation. If
Yeah.
the case is critical, then the auditor there will take
One
the
hour
role.
only, yeah.
If he's somehow stable, then the nurses around will do that.
Where?
Because
Oh, let's call Firas. Well, no, we settled it.
I think better to give it there, because this number is incredible to put them in small.
Right, okay. Who wants to move there? Who wants to stay? Who wants to move? Show of hands.
All of them there.
Who wants to stay? Who wants neither?
I don't know.
Are you sure?
Yeah,
Is the
yeah.
presentation up there?
Okay, we can to transfer there. A few steps.
It's going to be another delay.
Okay, so then I will call Firas.
Firas. And they'll, yeah. Okay. So any hospital they doesn't have news.
Most hospitals.
as myself, I've been working past 20 months in the hospitals.
What
I
hospital? Is
haven't
it
heard
government or
around the
private?
government, inside and outside the city. I haven't heard such a word like that, but we have many things to
Similar.
monitor patients. We have vital signs, classical command scales, according to the unit you are working with, like in surgical unit, cardiac unit.
Yeah, yeah.
Overall, the vital signs, they are really important for us.
Okay. Do you think
That's
this
fine.
is something you can apply in your practice or in the hospital? Yeah.
I think the only thing that we lack in our hospitals is that we don't have the chart. We have the scores. We always write what is the respiratory rate, what's the
Yeah.
pulse rate, everything. But
Yeah.
the thing that we lack is the chart. If the chart is added to the file, it would be great. Just
That's
that
not-
simple.
That's
not
not
the
the only
problem.
point. We may have the chart, but we need someone that sticks to the chart.
Sticks to the chart.
So the nurses or
Yeah.
the ones that, like, someone to look up to it and sees the interactions, the deterioration. Otherwise, the chart
Are
can be
available.
provided.
Yeah, can be provided.
So
But we don't have lots of
No.
just nurses.
for
college
now,
nurses.
how do you do it then?
Well, in FMC
Firas,
it's done
Yeah.
because of the nurses are qualified. They can do it and they can we both are aware of the situation of the patient.
Okay.
But in the governmental hospital, it's not so much.
Okay, so there's a
practice.
gap between
Yes.
the two settings.
Yes.
Okay, Dr. Firas, all yours? Huh?
After that, you are moving to the
I'll see.
After break, I think is better.
ممكن نروح على الكاس
Okay.